Good morning, everyone. We welcome you all to OrthoTV online. Today we have a medico-legal webinar, and I hand over the proceedings to our moderator for the day to introduce our esteemed guest speakers. Dr. Mullaji, over to you.
Thank you. So the subject for today is going to be consent and the medico-legal aspects of managing patients, particularly in the post-COVID era. So now a lot of restrictions are off, and we are now beginning to start treating patients. Patients are then going to ask for admissions, for surgery, and that's where a lot of this comes up. And the key question really that we want to address today is, for medico-legal purposes, we need to know the latest about consent, and we also need to know how to safeguard the doctor, the hospital, treating patients surgically, and also for conservative treatment. If they come into hospital, they are COVID negative, for example, but after surgery or after discharge, they become positive. What are the liabilities in terms of the hospital and the doctor? And can they actually legally sue either the hospital or the doctor or both for this? So this is the second part of the discussion. And we are very privileged and fortunate to have with us two very eminent people most suited for this discussion and to answer our queries. The first is Dr. Advocate Gopinath Shenoy, who is a man of many talents and wears many hats. He started off initially as a very successful gynecologist, an obstetrician, published several papers, had a very lucrative practice, and now specializes in medical law. He's also an examiner. He writes on medical law, he consults, and he's been honored with being considered India's 12 greatest personalities influencing medical practice by a very prestigious news magazine. So we are really privileged, and thank you, Advocate Dr. Shenoy, for being with us today. On the other hand, we have Dr. Shivkumar Utture, who is no less a luminary, president of the Maharashtra Medical Council. He's a member of the National Medical Commission. He's a professor of surgery at GMC, former head of surgery at St. George's, and also practices at Fortis and Shushusha. So we have these two very eminent personalities and who are eminently suited for giving us their opinion, backed by a lot of facts and figures, I'm told. And therefore, without any further ado, I look forward to the first presentation, which will be by Dr. Shenoy. So I will now go off the screen and request Dr. Shenoy. Thank you very much, sir, for joining us. So the screen is all yours.
Thank you, Dr. Mullaji. I hope I am properly audible. Okay, can I be heard?
Yes, very well, sir.
Okay, done.
Yes, you can be heard very well.
I've been given half an hour, and it's a very big topic that I've got to cover. So I'll go very fast. If at all there are certain queries, it can always be put to me during the question answer session. Okay. So basically, what is a consent? Consent is nothing but a contract between two parties. The party on one hand are the doctors and the healthcare providers, and the party on the other hand is the patient. So patient consents to get treated by the doctor, and the doctor consents to treat the patient. Basically, that is what it means. So in short, it's a permission given by the patient to be treated. Now, when it comes to consent, there are various forms of consent which you must know.
Excuse me, sir, you have to share your screen again. You have to share your screen again.
Okay, that's better.
Yes.
That's better.
Now just put on the slideshow. Yes.
Okay. That's what it is. That is where I am
yes,
now.
Just put on the slideshow. Yes.
Okay. Consent is basically a permission. That's what I just now told you. Now we'll go one step ahead. Now, normally consents have certain ingredients. So what is a valid consent? A valid consent must have 4 ingredients in it. The 4 ingredients are, it must be a free consent. The people who are consenting must have the capacity to, I'll explain everything, capacity to consent. The consent must be for a lawful act, and the consent must never be against morality or public policy. Now, amongst this, the first two are very important. The consent must be a free consent, that is what I said. When I say it should be a free consent, it means what? It means that the consent must be given without any coercion, without any undue influence, without any misrepresentation, without any fraud or mistake. Now, why does this become important? This becomes important in the COVID scenario is because of a particular thing that happened very recently. Recently, there was a notice sent to all the registered medical practitioners asking for their consent to work for 15 days in a COVID hospital. I think all of you all must have received it, and we are all aware of it. Now, is this consent a valid consent is the first question that I would wish to address. And in my opinion, it is not a valid consent because it is not a free consent. Why is the consent given not a free consent? Because if you read that particular notice sent to all the doctors, it very clearly states that action will be taken against you if at all you do not respond. See, I'm reading it. Non-attendance of duty will be considered as a breach of the MCI Code of Ethics, and we that we administered at the time of obtaining the duty, and action will be initiated accordingly. This word action will be initiated accordingly makes this particular consent a consent that is given with coercion. So whenever there is a coercion or an undue influence used upon a person who is giving consent, that particular consent in the eyes of law is not a valid consent and cannot be relied upon. I'm sure Dr. Utture would definitely give a comment on this, but this is what it is. The consent must be a free consent. It cannot be given under a threat that if you don't, I'm going to take action against you. Consent must, the people consenting must have the capacity to consent. That is, they must not be minors. They must be of sound mind. They must be very conscious, and they must not be under the influence of any drugs or any substances. Now, consent must be for a lawful purpose, because anything, a consent, a free consent, a valid consent given for an unlawful act really has no standing in the eyes of law. And finally, the consent must never be against morality or against public policy. Now, coming to the consent again, what are the various kinds of consents? Answer is very simple. There is an implied consent, which is also known as a tacit consent. You have an express consent. And in the express consent, there are two groups. Now, this is what is very important. The first group happens to be known as an informed consent, and this is the US concept. And the second group is something known as a real consent, and this real consent is the UK concept. I'll come to it a little later on. There is something known as proxy consent, that is when a pediatric patient is being operated, the parents give consent. That is purely a proxy consent. Now, amongst this, which is the commonest consent that is available in our day-to-day activity? Answer is the implied consent. Implied consent is consent by implication. When a person enters into the consulting room and he allows you to examine him, there is no express consent or written consent present, but the very fact that he walks into your room and he allows you to examine you shows that there is consent by implication, and in law we say that this is a tacit consent. Now, this implied consent is practically present everywhere. For example, when you enter into a train, there is a consent, there is an implied consent. The railway authorities agree or consent to reach you to your destination, and you accept the fact that the railway authorities are going to allow you and carry you and send you to the destination that you are expected to go. So tacit consent or implied consent is practically present everywhere. In medical practice, both tacit consent and express consent and proxy consent are all very important, as I'll come to it one by one. Now, there are certain situations where consent is not required. This is another very important thing you must understand. First is in medical emergencies, suppose there is no consent given, there is absolutely no problem. You can definitely operate upon the patient. And in such situations, the doctor is supposed to enter into the footsteps of the parents of the particular patient. And in law, it is known as loco parentalis. In Indian Penal Code, Section 92 is very clear on this, that if at all anything that is done in good faith for the benefit of the patient without consent is not actionable. Now, second important thing is, I think very few people know about this. In Criminal Procedure Code, there is one section by the name of Section 53(1). Section 53(1) gives immense powers to the police officer. The police officer can literally pick up a person who is an accused person and take him to a medical practitioner and get him examined by the medical practitioner. And the medical practitioner does not require the consent of the person that he is examining. Remember this. Third thing is, in notifiable diseases, you don't need consent of the person such that his disease is notified to the people. For example, if somebody is COVID positive, the doctor who is treating the COVID positive patient can definitely inform the authorities that this particular patient staying at this particular residential address is COVID positive, and the doctor does not require the consent of the patient. Next is the Epidemic Disease Act, the way we are going through today. Epidemic Disease Act also gives immense powers to the people concerned, such that consent from the concerned person is not really required, and this becomes very important when it comes to quarantining a patient. For example, if at all you have got to quarantine a patient, you don't have to take the consent of the patient. You can ask him to directly get admitted to a center, and if he refuses, and if at all he requires hospitalization, you definitely can use force by the help of police to see that he's picked up and is admitted to the COVID ward. So what I want to tell you is, consent of the person when it comes to Epidemic Disease Act 1897 is not required. Now, court-examined psychiatric examination also does not require consents. New admission to a prison, the prisoner's consent is not required to be examined. Immigrants. Now, this has been seen very recently. A lot of people have been flown down from all over the world, and at the airport, they all have been examined. Now, for this particular examination, you do not need consent. That is what I've got to tell you. Now, I'll go one step up. Now, my question is, can the courts force a medical investigation without consent? Are you understanding my question? Can the courts force a particular medical investigation without the consent of the person? And the answer is no, the courts cannot do it. Mind you, the police officer under the previous section that I told you, Section 53(1), has got immense powers. He can pick you up and get you examined, and the doctor does not require the consent of the patient. But can the court do the same thing? Answer is no. And this law has been settled by a very important case which really made a lot of rounds in the newspapers. This is Rohit Shekhar versus ND Tiwari. ND Tiwari is Narayan Dutt Tiwari, the big Congress bigwig. Now, in this case, what happened was, there was a boy by the name of Rohit Shekhar who said that he happens to be the son of ND Tiwari. And he went to Tiwari and asked him, "You accept me as your son?" And ND Tiwari said, 100%, I'm not going to accept you as my son. The moment this happened, a suit was filed for a declaration. It's known as a declaratory suit. And in the declaratory suit, the court asked ND Tiwari, get your genetic fingerprinting done so that we will come to know whether this particular Rohit is your son or otherwise. Tiwari said, I am not going to do it. Well, the court can only give directions, but could the court force Tiwari to undergo a genetic fingerprinting? Answer is no. Finally, this matter went to the Supreme Court, came back to the Delhi High Court, and the final order here in this particular case was given by the Delhi High Court, and the Delhi High Court said Narayan Dutt Tiwari should do his genetic fingerprinting such that what is what becomes very clear, whether Rohit is his son or not becomes very clear. But then it also said that if at all ND Tiwari does not do the genetic fingerprinting, then adverse inference must be drawn. This is all the courts can do. The courts could not force Narayan Dutt Tiwari to go to a hospital and get his genetic fingerprinting done. But then it said that we will draw adverse inference. And the adverse inference is that this Rohit Shekhar is your son. This particular case finally settled down. Narayan Dutt Tiwari accepted him as his son, and it settled down. But then it set down a very great precedent, a very good precedent, that courts cannot enforce any investigation on a particular person. Now, coming to consent laws in India. Now I'm coming to the subject proper. All this time it was just a little bit of a warm-up. Now, Before I come to the subject, I'll tell you something. Law of medical negligence and medical law are two different things. Medical law, normally people feel is the same thing as the law of medical negligence. No, law of medical negligence and medical law are two different things. Medical law is a genus and the law of medical negligence is a species within the genus. Therefore, you ask me another question. Are there any other species in medical law? Yes. Medical law has got two species within it. The first species is known as the statutory medical law, and the second one is the law of medical negligence. Statutory medical law means what? It is medical law where there is an act made either by the parliament or by the state assembly. For example, the Maharashtra Medical Council Act is a statute. It is a medical statute. PCPNDT Act is a medical statute. It's a medical law. For example, Medical Termination of Pregnancy Act is a medical statute. It's a medical law. Therefore, the other part, the law of medical negligence, is it a statute? Answer is no, it is not a statute. Then what is it? It is a pure judge-made law. What is negligence and what is not negligence is told to us by the judges of the higher courts, of the superior courts. Therefore, I call it as a judge-made law. It is also known as a precedent. It is also known as an authority. It is also known as a citation. It is also known as a case law. So, the law of medical negligence is a species within the genus of medical law. Law of medical negligence is a judge-made law. Therefore, to really understand what the law of medical negligence is, what must you do? You must read judgments, because in the judgments they tell you what the law is and what the law is not. Therefore, you must understand what is the doctrine of precedence over here. The doctrine of precedence says that whenever a judgment is given by a superior court, all judicial authorities which are inferior in hierarchy are duty bound to follow it. So this particular precedent or this particular law becomes binding when it is given by a superior judicial authority. Like for example, whether the doctors came within the ambit of the Medical Consumer Protection Act or otherwise was a big gray area. Some felt we came, some felt we didn't come. Finally, this matter went to the Supreme Court, and in a very important judgment by the name of IMA versus VP Shanta, the Supreme Court laid down the law and said doctors come within the ambit. Now, this particular judgment given by the Supreme Court becomes a law today, which is enforceable, and all judicial authorities which are inferior in hierarchy to the Supreme Court are duty bound to follow it. They cannot say that I am not going to do it. They cannot say it. So that is the importance of the doctrine of precedent, and that is the importance of judgments given by superior courts, which automatically have a binding value. Now, as far as we are concerned, the consent laws in India, we can divide the consent laws in India into three parts. The cutoff line is 16th January 2008, as I have shown it on the screen, because on 16th January 2008, the Supreme Court laid down the law very beautifully. It has been put, and the judgment that is concerned to settle the law on consent is Samira Kohli versus Dr. Prabha Manjit. I'll come to it a little later on. But prior to that, what was the law? We must understand. Prior to 2008, what was the law? This is something that you must understand. I'm purely on the law of consent. I'm not talking of anything else. So prior to 2008, express written consent was a statutory obligation only with very few acts. There was no clear-cut directions given by any authority that consent is mandatory. Consent is mandatory, a written consent is mandatory was mentioned in black and white expressly in these three acts: the Medical Termination of Pregnancy Act, the Transplant of Human Organs Act, and the Preconception and Pre-Diagnostic Techniques, that is the PCPNDT Act. It very clearly said. Now, if you read the Code of Medical Ethics also does say that whenever you are going to do some operative procedure on a patient, consent should be taken. It is definitely mentioned, but it is mentioned in the Code of Medical Ethics, and Code of Medical Ethics is nothing but a regulation. Remember, it is not an act. It is a regulation. So normally there is an act, there are rules, and there are regulations. There are three parts here. So these are the only three acts which mentioned it. Prior to 2008, absence of consent, people could very easily get away with. Why they could get away with, I'll tell you. And this particular law was settled in a very nice judgment by the name of Vadivel judgment. It's known as Vadivel judgment. Here, what happened, I'll tell you. There was a thyroid adenoma, and that thyroid adenoma was giving trouble. So the lady went to the family physician, got the adenoma shown. The family physician said, we will have to remove it. Family physician gave a reference note to a surgeon, Gopal Krishnan by name. The patient got admitted to the surgeon's hospital, got herself investigated, and finally walked to the operation theatre. See, I'm talking of law that is prior to 2008, prior to Samira Kohli judgment. So prior to that, this was the law. So this particular case happened in 1992. Now the patient walked into the operation theatre, GA was given, the thyroid adenoma was removed very successfully, there was no problem. But when the anesthetist tried to reverse the patient just could not reverse. Finally, the patient died. A DC was given, and in the DC, the surgeon said that she died of intracranial bleed. This was what the DC was. Well, finally, the matter went to the court. In the court, when the case was filed, there were lots of deficiencies mentioned. But one of the deficiencies that was mentioned was an express written consent was not taken by the doctor, and that amounts to deficiency in services. You know, finally, what happened in this case? In this particular case, the complaint got dismissed in spite of the fact that the consent was not there. It got dismissed. Why did it get dismissed? Whenever a judgment is given, the reasoning in the judgment becomes very important. And the reasoning given in this particular judgment was that in this case, the patient did not give a written consent, express consent. It is an accepted fact. But there was something known as an implied consent present. The court said that the very fact that the GP gave a letter shows that the patient was wanting surgery. The very fact that the patient got admitted shows that the patient wanted surgery. Patient walked in front of all the relatives into the operation theatre shows that the patient was wanting surgery. Patient allowed anesthesia to be given, and subsequently the surgeon operated. All these things show that the patient was willing for what was going to happen to the patient, and therefore, if at all express consent was not there, implied consent is very much present. This is the kind of ruling given. And I feel it is a very correct ruling at that point of time, because at that point of time, Samira Kohli was not there. But with Samira Kohli, the things change. I'm giving you this particular judgment to tell you what the situation was before Samira Kohli. Now, in this case, I feel that the judgment is correct because it can never be imagined that this particular doctor literally dragged the patient from the streets, dragged her to the operation theatre, forced anesthesia upon her, and tried to remove her thyroid and removed her thyroid. It cannot be construed that way. And therefore, at that point of time, this particular judgment was very correct. But today, the things change. I'll come to the change scenario. After this, I want to tell you something about extending the scope of surgery without consent. Normally, the consent is given for A, and the surgeon does something more than A, that is A plus B. One of the most initial cases, the first case or initial case was in 1923, a very old case. Here, what happened was there was a small wart-like growth on the penis of the patient, and when the patient was taken on the table, the surgeon identified that it was malignancy. And penile growths are known to spread very fast because penis has got a lot of good blood supply, blood bone very fast, and therefore what the surgeon did is the surgeon amputated the penis directly without the consent of the patient. This particular thing was done in good faith because the surgeon felt that the patient would not live for more than 2 years, and so he took this decision all by himself for the benefit of the patient. But somehow the courts, when the matter went to the courts did not take it lightly. The court said that it should not have been done. You should have amputated the penis of the person only with his consent. There was another very important case that took place a little later on, that is in 1933. Here, what happened was the patient was for a hernia repair, and when the hernia repair work started, the surgery started, the surgeon identified that the patient was also having a diseased testis. There was a gangrene of the testis. What the surgeon did, he removed off the gangrenous testis, and then also repaired the hernia. The scope of surgery was extended without consent, but somehow in this particular case, the complaint was dismissed because the court said that removal of a gangrenous hernia, a gangrenous testis, was the right thing to do. So absolutely there was nothing paid. Of course, there was another case that took place in 49. I'm giving you the rough idea of how the courts have been looking at it. In 1949, there was another case, and this took place in Canada, where a cesarean section was done, and the patient, the surgeon, found that there were multiple fibroids on the uterus. It was, see, 1949, sonographies were not there, everything was on clinical judgments. And so when he opened up the patient, he found fibroids. So he did a TL in good faith, seeing that this particular patient should not conceive again. But the matter went to the court because he did a TL without consent, and this particular complaint was allowed, and the surgeon gynecologist had to pay compensation. This is the world review. Now, what happens in India? In India, there are multiple cases prior to 2008, prior to Samira Kohli, where complaints have been allowed, dismissed, for even when the surgeon extended the scope of surgery. There was a case of LACS where there was a scar dehiscence, that is incomplete rupture of the scar. The relatives were very much present in the hospital. The surgeon did not consult the relatives and directly ligated the tubes, because whenever there is a rupture uterus, it is ideal that future childbearing should not be done. Extension of the scope of surgery without consent, but the court said that was the right thing to do, because most of the textbooks mention that whenever there is a rupture uterus, future childbearing should not be permitted. Ideally, TL should be done. Based on this, it was dismissed. And there was another very Grace Kutis case where, what happened? There was a placenta perculata and it just wouldn't come out after the cesarean section. So what was done was a hysterectomy was done. And during the hysterectomy, the bladder got damaged because it was an anterior placenta perculata. And then the matter went to the court. Here also the court said, well, whatever was done was perfect. There's no question of paying compensation. The complaint was dismissed. Now we come to Samira Kohli. And this particular judgment of Samira Kohli is very much applicable even today. That's why I've mentioned it. Post January 2008 to date, Samira Kohli judgment is applicable even to this day. Samira Kohli judgment is a judgment given by the Supreme Court. Samira Kohli judgment is a judgment that has been given by a 3-judge bench of the Supreme Court, and it is a dedicated judgment only on consent. If anybody really wants to understand what consent is, you must read this particular judgment. Everything with respect to consent is very much mentioned in this particular judgment. So what is Samira Kohli judgment? I tell you, there was a perimenopausal lady somewhere around 45 years who was having two problems. First thing is she was having severe pain during her periods. We call it as dysmenorrhea. And the second thing is she used to bleed for a long time, 10 days at a stretch, heavy bleeding, that is menorrhagia. She was sick and tired of it. And therefore, at 45, she went to her gynecologist, Prabha Manchanda by name, and got herself examined. And when she was examined, it was identified that she has got endometriosis. Dr. Prabha Manchanda discussed the fact with Samira Kohli and said that, well, the extent of the endometriosis is going to decide what is the treatment to be given. If it is initial stage, we can definitely fulgurate it, burn it by a laparoscope. If at all it's an advanced case, then there is no option but to remove the uterus, the tubes, the ovaries, that is, you have to do a pan-hysterectomy. But this can be identified only after the procedure of a laparoscopy. Clinically, it becomes very difficult to understand what is to be done, what is not to be done. So Prabha Manchanda got admitted. And when Prabha Manchanda got admitted, it was identified that she had a plastered pelvis. Everything was stuck. And when she had a plastered pelvis, the only option available was to do a hysterectomy. Now, what happened was, Prabha Manchanda, Samira Kohli was a perimenopausal, I use the word perimenopausal spinster. She didn't have a husband. So, who accompanied her was her mother. The mother was waiting outside the theater. So, Samira Kohli's mother was waiting. So, Prabha Manchanda told her junior to unwash and go and tell the mother. The mother was spoken to and the mother consented. That is, proxy consent was very much present. The mother consented. And what Samira Kohli, what Prabha Manchanda did was, she removed off the uterus, the tubes, the ovaries, a part of the cervix, and a small part of the vagina. Everything was removed. Surgery was difficult, but it was done. And finally, on day 5, when Samira Kohli was in her absolute senses, she asked the doctor, "What have you done?" And Prabha Manchanda told, "I have done a pan-hysterectomy." At that time, hell broke loose. Prabha Manchanda said, Samira Kohli said I gave you consent only for a diagnostic laparoscopy if required a laparotomy. I never gave you permission or consent to remove my uterus, my ovaries, and my tubes. So you extended the scope of surgery without my consent. And on this, a case was filed which went right up to the Supreme Court. In the National Commission, the case was dismissed, as a result of which the matter went to the Supreme Court. Now, the Supreme Court has given a very beautiful judgment on this. And what is the law today applicable on consent is this particular decision. The judgment given becomes the law today, and that becomes something very interesting to understand, but you will be able to understand it only if I discuss two very important judgments with you, because these two very important judgments are very much mentioned in the Samira Kohli scale by the Supreme Court. The two important judgments that is discussed by Samira Kohli in the Samira Kohli judgment is known as the Canterbury's judgment and the Sideways judgment. These are the two judgments that are discussed. Now, the Canterbury's judgment, Canterbury versus Spence, this is the American concept, and the concept of informed consent is laid down by the Canterbury's judgment. Informed consent is a terminology that is laid by the American courts. What does the informed consent say? Remember, I told you the varieties of consent. There is something known as a tacit consent or an implied consent. And second, I told you there is something known as an express consent. And in express consent, there are two varieties. First is the informed consent, and the second one I said was the real consent. Remember? Now I'm going to tell you what these two consents are. What is the meaning of the word informed consent and what is the meaning of the word real consent? See, informed consent means whenever you want to operate upon a patient, you got to tell the patient practically everything. I use everything. All material risk must be informed to the patient. The word is all. And what is the case law that laid down this particular doctrine? In Canterbury's case, what happened was Spence was a neurosurgeon, and Canterbury was a patient who was having a prolapsed intervertebral disc at T4 level. T4 level, there was a prolapsed intervertebral disc, and it was giving problems in the sense that both the limbs, the muscle power had reduced, and he was having problems walking. There was patches of paresthesia on both his limbs. The sensations were reduced, as a result of which the patient was fully investigated, and it was identified that it was the disc that was compressing upon the cord. So whenever this is there, you have to decompress it. And the patient was informed about what the problems were. But one thing the surgeon did not inform. The surgeon did not inform that there was a possibility that during the surgery, there can be a damage to the cord, as a result of which he will be paraplegic for the rest of his life. He will lose the control of his bladder for the rest of his life, and he will lose the control of his anus for the rest of his life. This particular fact was not informed. Well, the surgery was done, and when things go wrong, everything goes wrong. This particular patient was left on the wheelchair. Both his legs were paralyzed. He had a catheter for the rest of his life, and he had to have diapers for the rest of his life. When this happened, he went to the court. Canterbury went to the court and told the court, if at all Dr. Spence had told me that this could happen, maybe I would not have operated. The very fact that he didn't tell me, this shows that, well, everything possible was not informed to me, and the consent that I gave was a consent which was not an informed consent. And the court said yes. And that is how this particular word informed consent comes into play. Informed consent is an express consent which is based on the law of Canterbury versus Spence. And here, everything possible has to be explained to the patient before you take the consent of the patient. And when you explain everything to the patient is then equipped to take a reasonable decision for himself or herself. So that is how this particular word gets connoted, reasonably prudent patient test. Now, this particular patient becomes a reasonably prudent patient only when the patient comes to know all material risk that is involved with the case. I'm also repeating it, all material risk has to be discussed. Now, this Canterbury's case took place in 1972. Remember, 1972. Now, subsequent to that, there was another small problem that took place in the UK, and this is known as the sideways case. Both these cases are mentioned in the Samira Kohli judgment, and that is why I'm elaborating on it. In sideways case, what happened was, again, there was a prolapsed intervertebral disc, and this prolapsed intervertebral disc was at the level of the neck, cervical vertebrae, as a result of which it was giving weakness in all the four limbs, both the upper extremity and the lower extremity. There was a sensory deficit both on all the extremities. So when the patient was investigated, the English surgeons told the patient that you have got to get yourself operated, but they did not inform the patient that there was a risk that the cord could get damaged during surgery, and that is exactly what happened. The patient was taken up for surgery, and during the surgery, the cord at the cervical level got damaged, as a result of which both the upper limbs and the lower limbs were totally incapacitated, as a result of which the patient was on a wheelchair for the rest of her life, catheter within her, diapers to take care of the fecal matter that she used to pass involuntarily. The matter went to the court. And when the matter went to the court, you know what the British court said? This happened in 1985, and the previous case happened in 1972. Remember, it was practically 13 years that Canterbury's law was very much established by the American courts. But the British court said, we are not going to go by the Canterbury's law. You are understanding me? The British court said the patient need not be informed everything that is possible, everything that can possibly go wrong with her, because if at all this is told, required surgeries, many surgeries which are very much required might not be done. The last third paragraph here is very important. This is what the courts have said. The British courts have said, remote risk of damage referred to as risk at 1 or 2% need not be disclosed. But if the risk of damage is substantial, referred to as 10% risk, it may have to be disclosed. Are you understanding me? So this particular law, this particular consent that is to be taken, in the eyes of law, the British courts have said that this consent taken in this particular manner, where everything is not disclosed, everything that is more than 10, the risk that is more than 10% is disclosed, it gets connoted as the real consent. Remember, real consent, you need not discuss everything. It is a British concept. And in informed consent, you have to discuss everything possible. So this is basically the difference, but the British courts did not accept the doctrine of Canterbury. They said, no, you need not discuss. Now the question is, what is the law that becomes applicable to India? Are you understanding what I'm saying? So in India, we've got two things in front of us. You've got the American concept of informed consent, and you have the British concept of real consent. And this is what the Supreme Court says in Samira Kohli. See, this is what the Indian courts have said in Samira Kohli's case. In para 33, the Indian courts in Samira Kohli says, we have, however, consciously preferred the real concept involved in Bolam and sideways in preference to the reasonably prudent patient test in Canterbury, having regard to the ground realities in the medical and healthcare in India. But if the medical practitioners and the private hospitals become more and more commercialized, and if there is a corresponding increase in the awareness of the patient's rights amongst the public, inevitably a day may come when we may have to move towards Canterbury. But this last 5 words are very important, but not for the present. So the Supreme Court had to decide today what becomes applicable. Does the informed consent as laid down by Canterbury becomes applicable to us in India, or the concept of a real consent becomes applicable to the population in India? And para 33 of the Samira Kohli case is very clear. It says that as things are today, real consent becomes applicable, and the doctrine of Canterbury, informed consent, is not applicable. Now, mind you, this is the decision of the Supreme Court laid down by the Supreme Court, a 3-judge bench. 3 judges sat and they have decided this particular case. And if at all any other judgment has got to overrule this particular concept, the overruling has got to be done again only by the Supreme Court. This particular law cannot be changed by the National Commission, cannot be changed by the State Commission, cannot be changed by the High Courts of any of the states, cannot be changed by any judicial or quasi-judicial authority. This is the law today. If anybody has to change this law can only be changed by the Supreme Court. Now see the I'll read a small part of this. Why the Supreme Court decided in this particular case is something to understand. It says, having regard to the ground realities in the medical and healthcare in India. Now, what does the court mean by this? See, in the judgment, it is also elaborated, but I have not picked it up as a slide. The Supreme Court says the population in India are absolutely illiterate. They don't know what is what. If at all the doctor were to tell the patients everything possible, the patient might just pack up and run away. A surgery that is very much required might be just, not consented to. Just imagine you tell the patient there is a remote possibility that you might not just come out of anesthesia. I'm going to give you anesthesia, but there is a remote fraction of a percent that you might just not come out of anesthesia. Just tell the patient that. What's going to happen? The patient will say, I don't want you, I don't want your surgery, I want to run away. Suppose you tell the patient there is a remote possibility that you might die on the table, because that is a fact that is very much present. That is an inherent risk with any kind of a surgery and anesthesia. If at all you tell the patient there is a remote possibility that you might die on the table, a surgery that is very much required. For example, suppose there is a strangulated hernia and the person has to be operated upon, and you tell the patient there is a possibility that you will die, a surgery that is very much required might just be refused by the patient. So the Supreme Court has said that this is the ground reality, and that is why we are embracing the doctrine of real consent, and we are discarding the doctrine of Canterbury, that is informed consent. But the Supreme Court goes one step ahead and says that, see the last two lines, inevitably a day may come when he may have to move towards Canterbury. That means in future that it might be possible that we might need to go back to Canterbury. But the last 5 words are very important, but not for the present. The Supreme Court has said, as of today, it is not required. Canterbury's doctrine is not required. What we require is just real consent. So now, the Supreme Court has laid down the ingredients of the consent over here. And the Supreme Court says in this is para 32 of the Samira Kohli judgment, it says a doctor has to seek and secure the consent of the patient before commencing treatment. And the second thing it says that the consent, the consent must be valid. I told you what a valid consent is, and real. Consent, number 2, just see this number 2. The consent so obtained should be valid and real on the basis of adequate information. All information is not required to be given. Adequate information is what suffices to be given. Therefore, informed consent as laid down by the American courts in Canterbury is not required to be followed by the Indian doctors today. What is required to be followed by the Indian doctors today is the real consent as laid down in the sideways case by the UK courts. The last one is very important over here. The 7th point. I'm reading it for those people who do not have the slide in front of them. The nature and the extent of information to be furnished by the doctor to the patient to secure the consent need not be, I'm repeating, need not be of the stringent and the high degree mentioned in Canterbury. Remember, Canterbury is a high degree where everything is possible. And sub clause over here, clause 6 becomes also very important. It says there can also be a common consent. Remember this. There can also be a common consent for a particular surgical procedure and an additional or further procedure that may become necessary during the course of surgery. And that is why I've always been saying, whenever you have draft a consent, this particular clause must come in so that you can extend the scope of surgery without consent and you get covered, because the Supreme Court says if at all there is a clause of this kind put in the consent, you automatically get protected. See, I repeat, there can also be, see, there can also be a common consent for a particular surgical procedure and an additional or further procedure that may become necessary during the course of surgery. So this has got to be incorporated in the consent. Now the question is, who should take the consent? This is a very common question. The junior doctor took the consent, the consultant did not take the consent. Now, a lot of things come up in the court, and the answer is, once again, in Prabha Manchanda's case, the Supreme Court has answered this question. The adequate information to be furnished by the doctor or a member of his team. Remember, if at all your junior, your RMO take the consent, it is perfectly all right, because the Supreme Court has categorically gone on record by saying the adequate information. Remember, real consent, the British concept is adequate information. Canterbury consent, American consent is all information. That is the difference. The adequate information to be furnished by the doctor or a member of his team who treats the patient. So this is the person, any person from the team can definitely take the consent. Now I told you the Supreme Court has said a time may come when we may have to go to Canterbury. Now what is the future of consent? This is something I have to tell you all. Now the future of consent is this. In UK, what happened was the sideways, the real consent, the sideways concept of real consent ruled for practically 30 years. 30 years it was the law. And in the year 2015, this particular law was changed by the Supreme Court of UK. Supreme Court of UK changed. And the judgment that changed this particular law was the Montgomery's case. Now, Montgomery's case, what happened, I tell you, and how the law got changed, I tell you. In Montgomery's case, there was a lady, a full-term pregnant woman. See, most of the examples that are given are from obstetrics gynecology. You know why? Because maximum cases are with respect to obstetrics and gynecology. Maximum cases all over the world, not just in India. India, 100% it is there, but all over the world, it's the same thing. In Montgomery's case, what happened was there was a lady, a primary, who was full-term. Everything was nice, good pelvis. The doctor decided to go in for a vaginal delivery. And the vaginal delivery was conducted. And when the vaginal delivery was conducted, there was a shoulder dystocia. The head came out and the shoulders got stuck. It was like a turtle. It's known as turtling effect. The head is out, the rest of the body of the baby is in. And whenever such a problem happens, the baby has got to be delivered within 4 minutes. And if at all it goes beyond 8 minutes, the baby does not survive, because beyond 4 minutes, there is anoxia to the brain. And there can be some amount of residual damage. Cerebral palsy can get set in. In this particular case, there was shoulder dystocia. There was a lot of trouble getting the baby. There was some amount of cerebral palsy in the baby, and the matter went to the court. And here the lady said that in Montgomery's case, she said that if at all I had told that there was a remote possibility of a shoulder dystocia, I would have opted for a cesarean section. This was the case. Well, shoulder dystocia was not the issue at all, because the standard treatment protocols were very much followed.
So sorry to interrupt, but
last case.
Yeah, just
1 minute. I'll take another minute. I'll stop.
Yeah. Thank you.
Okay, another minute. I'll stop. Montgomery's case. The English courts, after 30 years, changed the law. The English court said that it is high time that we embrace the Canterbury's principle. Everything possible must be told. Now, this Canterbury's principle, this particular Montgomery's case was decided in 2015. Samira Kohli was decided in 2008. When Samira Kohli was decided, this particular case was not there. Now, if at all the matter once again goes to the court, the Supreme Court may consider Montgomery's case and bring about a change in the law. But it is only for the Supreme Court to do it, and that too, it has got to be done by a Supreme Court bench that comprises of minimum 3 judges, because this particular judgment of Samira Kohli had been delivered by the Supreme Court, a 3-judge bench. With that, the law of consent is very clear. As of today in India, informed consent is not required. As of today in India, what is required is the real consent. As of today, all possible complications need not be discussed. Anything that is more than 10% should be discussed. If at all it is less than 10%, like a cord damage is supposed to be 1 to 2%. It need not be discussed with the patient. A day might come when all this might change, and we too in India might go towards the Montgomery's case. With that, ladies and gentlemen, I hope I've made things very clear. Back to you, Dr. Mulaji.
Thank you very much, Dr. Shenoy. That was actually very illuminating. You went in great detail, and I think this is very important because all of us who are operating need to know exactly what consent means, who should take consent, how much should be disclosed to the patient, not only for COVID patients, but for our routine surgeries that we do, or even for unusual surgeries. And the point that you mentioned to add additional surgeries, additional procedures that may be required is a good idea in your consent form, just in case the scope of the surgery changes intraoperatively, then you're on a safer wicket. So with that, please hang on there. We will be asking you questions, so don't go away for lunch, sir. Now, Dr. Shivkumar Utture, it's our great pleasure to ask you to please give your views on consent, and with a particular interest with the COVID crisis, of course. And I welcome Dr. Arvind Kulkarni, who I think was tied up in surgery and has just shown up. He was probably decompressing some cord that Dr. Shenoy was referring to. So I think, Dr. Utture, please, let's hear you.
Yeah, so I think now I should say good afternoon to everybody. And I think after that great talk by Dr. Shenoy, I think majority of us have already passed the first LLB exam. It's part one. So he has given you an extensive details of how consent started and at what stage it is now. So he has reduced my job to a great extent. And when he was talking, I have been sitting and removing some of the slides which were there, which he has already, spoken about. So I'll just be talking. A few slides may be repeated, but that is for the practical aspect of what I would be talking. I have divided this talk into two parts. The first part is the general consent, and which is going to be relevant, where part two will come of what we require to do in this COVID era. I think what was the very first slide, and thank you, Dr. Mulaji and Vijlani, for having called me here today. The first slide was consent in post-COVID era, but today we are in the COVID era. And let me tell you, this COVID era is going to go on extending for a minimum, at least for the next 1 year. So let us talk about what we are supposed to do as far as the in COVID era is concerned, because everybody of us wants to go back to work and do our routine surgeries and routine work. So Dr. Shenoy has already, spoken about this, that it has to be what is exactly a consent. It has to be free and voluntary, as he has already told you. I will not go into the details, but what you have to understand is that prior provision of a consent signifies a possible defense against civil or criminal liability. So whatever anybody tells you, let me tell you, a consent is a must. And what type of consent you take is not only going to depend on what type of surgery you are going to do, but also what type of patient you are handling. Because though we spoke about Canterbury and this, it has said in the last line that a day may come when you may have to take the express consent also. And that is what is happening in majority of the corporate hospitals, where they are taking express consent now and not sticking to just the real consent. So what has happened over the years? Doctors are no more gods. There is a great change in the doctor-patient relationship that has happened, and especially because of that advancement of technology. So if you see that Supreme Court judgment which was there, which was asking you to take real consent, was before this era of technological boom that has taken place. Today, the patients go online and check everything and then come to us. And hence, they are quite well educated and they know what is expected of the doctor to do. So if you don't want to get into a legal hassle tomorrow and go right up to the Supreme Court to get anything changed or, save yourself, I think you should take consent in a proper manner. And let us come to see what exactly is the proper manner going to be. Today, the patients know that they have a right, and they have a right not only to choose the treatment, but also the right to choose which type of doctor they go to. So who has the ability to give you the consent? That is laid down in the law. It is 18 years. He has to be mentally sound and not be in a sedated or intoxicated state. I'll come to that in my further slides, why this intoxicated and sedated is the most important thing. See, I'm going to touch upon only the practical aspect. The law point, legal point, he's already touched upon. I'm going to touch upon with my experience practically of sitting in the council for almost last 8 years of what are the problems faced by our members when a proper consent has not been taken. So you see, what are the situations requiring consent? So whichever patient, he has gone into detail as far as what all these are concerned, and what I have put down in red is basically what is most important. If you try to treat a patient without a valid consent, then you're liable for both tort and criminal law. So you can be pulled up in a criminal case, you can be pulled up in a civil case, that is under the Consumer Protection Act, or even a civil case standing, that is a medical councils which are there. So these are the basically what will happen to you if you have not taken a proper consent from a patient. Then, of course, he has already touched upon this. A little bit change I have made in this practical so that everybody understands that implied consent, as he said, as you know, is meant basically for examination and for routine treatment of that patient. But then the next two parts are important, that is the express consent and the informed express consent, as we call it today. So express consent can be oral, can be written. Implied consent, he has already spoken about it, and this importance is going to come. I'll come in the further slides because of the new concept. A lot of questions are being asked as far as telecommunication, which has been allowed by MCI and has been allowed by the Maharashtra Medical Council also today legally. So we'll come to that when I come to that slide as far as what is this type of, because implied consent comes into play over there. But as the last line says, that if there is a slightest chance of any complication, express consent must be taken by one and all. So as far as express consent is concerned, there are two forms. One is that in the oral aspect, that is whenever you know, for body removal of body fluids, or simple example, if you're putting in a Ryle's tube, you don't, or you're putting in a catheter, you don't require an absolute written consent from these patients. But it is always better if you write down on your paper that the patient has been informed that today Ryle's tube is going to be put and he has consented. You may not take a signature, but it is always for your safety, you can put it down on the paper. But if you are going to do anything beyond that, like say for tapping purposes or anything, I think there you have to have a, you know, even for a simple CLW suturing, if you are going to do, you have to have a written consent, because that is what you're doing something actively for that patient. So anything that is invasive, may it be diagnostic or may it be therapeutic procedure, or it leads to any medical legal examination, definitely and written consent must be taken. So as far as the informed consent, I'll go a little bit in detail in this, because this is what is going to be the future, even if it is not there in India today. As we say, we stick to the real consent, but then as the days pass by, and let me tell you, informed consent has been explicitly mentioned in the, you know, Transplant Act. You're supposed to give all the details in the Transplant Act when you take the consent of you know, both the parties. So it is coming informed consent, and that this is going to be what is going to be the future as far as we are concerned. So what it is defined as voluntary acceptance after full understanding by a competent person. That means mental capacity of that person is extremely important, that he understands what he says. If you feel that something is wrong where he will not understand what you are telling, so if he's an uneducated person and you want to explain to him something, a big complication in whatever you're doing, then always have a relative who understands this with the patient. A complete information must be provided. I think that has already been touched upon by Dr. Shenoy. I will not go into details of that. The voluntary acceptance of the procedure has to be there on the part of the patient. He should not be forced to, you know, accept whatever you say, and should be person and procedure specific. This is most important with the few of the judgments that we have seen, that if you are taking a consent for a particular procedure, unless it is an absolutely life-saving procedure, you cannot go beyond that. And that also, I think Dr. Shenoy has, you know, already touched upon that. Then a lot of people are asking me in what format should the consent be there. So it should be a documented consent whenever informed consent is there. And at the end, there has to be a signature of the patient. It is always better to take the signature of the relatives also who is there with the patient. Then many questions have been asked as far as the video recording is concerned, because that is being done in majority of the corporate hospitals today. Yes, video recording consent you can take, and it is always better to take, because the details of what you talk to the patient in a video recording, you cannot put it down on paper when you are taking a written consent from that patient. But one thing you have to bear in mind, that whenever you do a video recording, the prior permission of the patient has to be there, that you are recording this consent of that patient. So you have to take that prior permission of that patient before video recording. And this is something which is there in all the law points, doctrine of full disclosure. And what is that? So basically that has multiple parts. Number one, that there is an alternative treatment also possible, especially I think a lot of orthopedic crowd is going to be over here today. So are you going to operate, or are you going to treat it conservatively? So you are supposed to give disclosure to that patient of the treatment that you are suggesting, but there are other treatments also, and what are the pros and cons of that other treatment and your treatment. So you are supposed to give full details. And then of course the prognosis and the possibility of the risk factors, and of course here the major risk factors should be told to the patient. So suppose you are doing some fracture or something, shortening of the limb or non-union, all these things have to be mentioned to the patient, and the patient has to be aware of all these problems. Like how, if as a surgeon I am doing an abdominal case, there could be a burst abdomen, there could be a infection of the abdominal wound. All those things have, in today's era, with an educated patient, you are supposed to give all this information to the patient. And of course again, the mental capacity and the physical condition of that patient has to be seen whenever you are taking this consent. And when do you take that consent is the most important aspect. Invariably what we do is, in our private practice, we admit the patients in the morning, and of course if your anesthetist has said give a sedation, the sedation is given, and then a consent is taken by your nursing staff or by your RMs. Remember, that is not allowed, because number one, on the day of the surgery or nearing the time of the surgery, mentally the patient may not be in a proper frame of mind to give you the consent. So it is always better to discuss with the patient as far as the consent is concerned when you're fixing up the surgery, so that the patient knows exactly what he is undergoing, what could be the complications, etc. And try to get a consent either on the prior day or before any of these pre-anesthetic agents have been given. So do not take a consent at the last moment, especially when the patient, this, especially we see this when we are doing any small cases where the patient walks in and you're giving a short GA and doing, some fixation or just, giving a cast or something like that. And then you take the consent of the patient when the patient is being wheeled into the OT. That should not be the case, because that can go against you in the court of law. Then what are the different aspects? Blanket consent is not valid. It has to be very, very specific. So there was a time, I remember in our residency days, we used to have one single sentence that I am willing for any surgery under any anesthesia, and then he used to sign. No more is that allowed. You have to specify which surgery, what you are supposed to do, everything. Then if there is a repeat procedure, you have to see that you take a repeat consent. A second consent has to be taken. Simple example is that if you are operating a patient and then post-operatively you find that there is internal bleeding going on and you want to take up the patient again. So if the patient is of sound of mind, that means he is not in a very serious condition, a repeat consent of that patient has to be taken if you are going to do the second surgery. Many a times in the council, there have been cases where the patient has said that when there was a complication, we were never told of what the complication is there. We were never told that he would require another major surgery, and a consent was never taken for that surgery. We could have shifted the patient to some other bigger institutes or tertiary institutes. So that should not be the case. Another very, very important aspect of all operative cases is that, remember, there must be a separate consent for the surgical aspect and for your anesthesia cares. And this I must insist that all anesthetists, even if that institution does not have a separate printed form of anesthesia consent, please have your own form and take the sign of that patient, because anesthesia becomes a completely different department and the surgical aspect is a different department. You can have complications because of your anesthesia for which you can be pulled up. So consent should be properly documented. That means why I have put down this point is that many a times whenever there is a case coming up in the council, the consent form is produced because if unfortunately there is a mishap, the police come, and the police, what they do is basically they come and they take away all your papers. Along with that, they take away your consent forms and OT notes and everything. And then many a times what we are finding is that what the sister has done is she has only written the name of the patient on top. Everything else is blank. The fill in the blanks have not been filled. And there is only the signature of the patient below that. So no, what is the type of surgery to be done? Nothing has been written. So this is not a proper documentation of that consent. And I always, a practical aspect I tell all my friends is, you may not take the consent, as already told by Dr. Shenoy, that it can be taken by a RMO, it can be taken by your sister, but get into the habit of signing this consent form before you enter the OT. Because when you sign that consent form, you definitely look at all the blanks that have been left behind, and you have to fill up those blanks before you start the surgery. Then, of course, everybody asks, do you require the consent of a relative? It is not a must as per law. If that patient is 18 years and above and mentally sound, you can have only the consent. But then to be on the safe side, because tomorrow if something happens to the patient, for your safety, it is always better to take consent of one of the relatives also. So, having in short told you whatever the practical aspect of consent is there and what we were following up till today, now let us come to this era of COVID. How things are different as far as the COVID era is concerned. And what is the difference? Now, whole management itself is going to be different pre-COVID and post-COVID. And therefore, even your consent, how you take the consent and what you note down on the consent is going to be extremely important for your future. So what are the differences, what are the deviations that are there in the standard management today? Number one, and most important, that all of us, especially working in small nursing homes or our own setups, is that limited resources that we have got today of both the staff and the equipment. Half our staff are still not yet joined the duty, so it's going to be very difficult for a number of especially when you're taking high risk patients. Not only that, as far as COVID is concerned, we'll come in the next slides, that you may be requiring an ICU or a ventilator, which you may not, all the nursing homes do not have unless they are very large nursing homes. So that itself also you have to take into consideration. Then, of course, the risk of nosocomial COVID-19 disease acquired is always there. We will come to that also. Increased risk for your medical staff to especially wherever there is aerosolization, and this is very important. Orthopedics, and of course in any laparoscopic surgery that we are doing, the chances of they getting infected is very high, and we have to take that into consideration in the future also. Then intensive care therapy, that is limited availability is there in the COVID era. Why we require that, I'll come into the next slide, which I'll be talking. I'm just talking about what are the deviations we are going to be facing in the future during this era. Then, of course, technically challenging if conducted in personal protective equipment, especially there are cases where sometimes we have to do for 2 hours 3 hours for a long time. And today, imagine, what we are telling all our colleagues is that every patient you have to treat him as if he is COVID positive whenever you are taking him into the OT, and therefore you have to have the full PPE on. And a person who wears a PPE understands how difficult it is to work in an PPE, and on top of them, operating under that full PPE is going to be extremely difficult for us. So that also we have to take into consideration. Both our efficiency, our patience, and everything will go down as that time factor increases. So we have to take that into consideration. And especially in such situations, you should have a very good assistance with you. Maybe till date we were doing some surgeries on our own alone, but it's high time, because I have worked in the hospitals also where they are treating COVID patients. Some of our colleagues within 2-3 hours, even working in a normal COVID ward, they have collapsed because purely because of wearing that PPE and getting exhausted under that PPE. That has to be taken into consideration. Then, of course, treatments that render patients more susceptible to COVID disease, especially those who are with got high morbidities, like they are on chemotherapy, or they are elderly with high diabetics, especially uncontrolled diabetes, hypertension. That has to be taken into consideration. And of course, the main important point that even today you are seeing that every weekly, or every, sometimes even every within 2-3 days, even the WHO and ICMR are changing their protocols and their directives that they are giving us, because this is a completely new disease that we are handling. And let us accept that we know very little as far as this disease is concerned, and what are going to be the surgical outcomes, because there are some papers, and I will show you the details also of that, of how even this disease being, I mean, if a patient is positive, how he is affected whenever we do these surgeries. And if the patient contracts or develops COVID-19 while in hospital, recovery from the surgery could be made more difficult with increased chances of serious illness or death. See, you have to understand that the symptomatically the patient becomes positive after about 5 to 7 days. So when he walks into your admission or into your theater, there may be no symptoms as far as COVID is concerned, but post operatively he develops these symptoms. That is going to be an extremely difficult situation for you to handle. I am not talking of your liability as far as the patient getting infected or not in the operation and then suing you. I'm talking about looking after the post operative patient, who is going to deteriorate very fast if he is COVID positive whenever you do any major surgeries. And one thing I would like to tell you is, many a times I've been asked this question, that what if the patient becomes positive afterwards, post operatively, and he blames the doctor. Let me tell you, I have spoken to Supreme Court lawyers and judges about this subject also. The onus of proving that he has got COVID in the hospital is on the patient, which is going to be very, very difficult for him to prove, because he may have got it pre admissions. As I said, the symptoms of the sometimes the positivity when we do a test may come up almost after 5 days of after being exposed to this disease. Not only that, he has got a lot of relatives who are coming and looking after him. He may have got it through them. So there are different factors which have to be taken into consideration, and it is going to be very difficult for him to prove that it is he has got this disease when he was admitted in the hospital. So I don't think we have to bother much as far as that is concerned. Even if you have done the preoperative PCR test and it is negative, we have to understand is that the PCR test has got its own limitations. As they say, even if you take a nasopharyngeal swab, there is almost 35% false negative that can come. And many a times we have found that it has come negative, then after the patient's symptoms have come in and we have retaken the PCR test, it turns out to be positive. So that is also there. So it is very difficult for anybody to prove that you or your hospital has been the cause of him getting this disease. So what is the added responsibilities whenever we are taking this consent? And I've kept this word informed consent, though I know Dr. Shenoy will not agree with me, because in India it's not yet come into play. But as I said, we are talking about the future. So let us be ready for the future and let us get into the habit of taking this informed. You don't lose anything by taking informed consent. You may lose one or two patients because you have told them all the details, but I think that is better than losing 10 years of your life, or then you'll have to run to Dr. Shenoy every time to get you save your skin in different forums like the consumer protection or the high court or the Supreme Court. So it is better to be to err on the positive aspect than to try to compromise on taking these consents. So you have to understand the significant scientific, ethical, and moral uncertainties are there when you are treating any patient during this COVID era. So what is expected of you during this era is complete transparency of the potential but unknown risks which are there. So you have to bring it to the notice of these patients that these are the problems that you may face, that I may face during the surgery or post-operative period. So you have to give them all the details, because it is the right of the patient today to know what he is undergoing when he puts his life in your hands. So you have to talk about the risk of proceeding under the current circumstances versus the real risk of delay. And this is what is extremely important when I tell all, even today I tell my colleagues who ask me, should we start routine surgeries? Like for instance, I am a surgeon and there is a hernia, and especially if it is an direct type of a hernia where the complication is also almost unknown of any obstruction or anything, why do you want to take the risk of operating such a patient? You wait for some time, wait for 6 months. Maybe once there is some treatment or some vaccination, or we understand this disease much better day by day, there may come a time where you will be, quite in a peace of mind to go ahead and do these surgeries. So if you can wait, you should always wait as far as the surgery is concerned. Or you have to take a balanced view. If there is a risk of delay, like for instance it's a malignancy surgery, or suppose he's got an appendicitis or a cholecystitis, there is up to a certain period you can wait, but beyond that you cannot wait. So this balanced clinical judgment you are supposed to take. Not only that, you have to also talk to the patient as far as that the treatment that you are giving him in this era may not be the one which you would otherwise give him before the COVID era. To just give you an example, like we always say that the problems of laparoscopic surgery for a patient and for even the health staff is much higher than doing an open surgery. For the patient, because laparoscopic surgery, he has to undergo general anesthesia, where the complication rate is definitely much more. Suppose I'm doing an appendicectomy, it is easier to do it under a spinal anesthesia than a general anesthesia in this COVID era. Not only that, because of the aerosol problems, chances of you getting infected, chances of infecting your hospital staff, your nursing staff is very high. So maybe doing a laparoscopic appendicectomy is the golden this as far as pre-COVID era is concerned. But then you'll have to explain to the patient that in this era it is going to be very difficult for me to give you this treatment, so I'll give you the next best treatment, and that is an open surgery. So be very transparent with the patient. And let me tell you, I have been operating also during this era, and once you explain to these patients, they agree for getting the surgeries done. Remember, patients go online, and patients find out online that there are there greater advantages of getting a laparoscopic surgery done than an open surgery. But they don't understand that during this era that there are some limitations that are there, even as far as the doctor is concerned. So if you make them understand that, they will definitely be amenable for accepting the treatment modality that you are giving to this surgeon. Then of course, what are the challenges that we are facing? The challenges are that post operatively, the chances of the patient requiring ICU is going to be very high. See, today whenever we take a consent, we rarely ever tell the patient that you will require a post-operative post-operative you may require an ICU treatment, or you may require a ventilator. But today we will have to talk about that, because if you see over there the second para that is said, that there is, of course these are very small studies that have been made, because this is a new disease. But there is definitely there, these studies are there where they show that 34 operative patients with who turned out to be COVID positive, out of which 44% required ICU care. So imagine today, if are you going to tell the patient that do we tell the patient pre-COVID era that 44 patients, that means almost half your patients may require ICU? We don't tell them. But the time has come for us. You may not say 44%, but that there is a chance that you may require an ICU treatment. And the mortality amongst these positive patients is almost 20.5%. These are documented papers which have come out. So you have to take this into consideration whenever you are taking a consent from this patient. Then Of course, then lack of pre-operative COVID testing in India that is something that we have encountered very much. And many of my colleagues asked me that, do you always take pre-operative COVID test done? Yes, in between they had given an advisory that you do not require to take if the patient has no symptoms. But then we have been fighting with the government, and to some extent they have agreed that pre-operative, especially in major surgeries, pre-operative COVID tests must be done. So whichever surgeries you are doing under GA, please do a pre-operative PCR test done. Another thing always asked by my colleagues is, should I go and do an HRCT done? We are finding that if you combine PCR test with HRCT test, almost 94% of the patients can, you may not diagnose, but there is probability that they may be COVID positive. So if you see any ground glass appearance on HRCT, and even if your PCR test comes under the false negative, it is always better if you can wait. I'm not talking about emergency surgeries, which you have to go ahead thinking that they are COVID positive and taking adequate precautions, but which are elective surgeries. Please get a repeat PCR test done, especially if the HRCT is showing ground glass appearance and pneumonitic patches. You get it done, because we have found that the chances of, when you do 2 PCR tests, the positivity rate is much, much higher. Then, of course, the need of ICU in post-operative period must be this, which I've already told you. Sorry, we are on the last line now. So we have to get these COVID tests done. And as much as the government tries, we as surgeons will be fighting with the government to allow us to do these pre-operative tests. Then I think this is as far as the consent and what are the extra things under the consent which we have been taken up till now, and what is the difference that our consent form is going to be, a format is going to be in this COVID era and post-COVID era also. There is not going to be any post-COVID era, take it from me. We are stuck like how we are stuck with influenza. We are stuck with this virus for life. It may come in, much less virulence, but it is going to come in the future also. So now let me just touch upon another thing, that as far as consultation, that teleconsultation, which has been allowed by the board of governors also, and we have also in MMC, we were the first council to allow a telephonic consultation during this period. So now invariably they ask us, how do you take a consent when you go telecommunication? See, when you give a telecommunication, you don't do any operative procedures at all. And this comes under what we have already discussed, implied consent. The very fact that the patient has taken or come to you on the either on the telephone, or he has come to you on the WhatsApp media, or a video conferencing that you have done, he has already given you an implied consent for you to treat him. So you do not require to take any special or specific consent from him for doing telecommunication. And you have to understand this 3.8.3 point, where it is written over there that telemedicine practice guidelines are not applicable to the use of digital technology to conduct any invasive procedures remotely. So you are not allowed to do any procedures as far as telecommunication is concerned. So you don't require any very specific consents. It is the same thing as a patient would walk into your clinic and you have examined him and you have given him a prescription for the drugs that you do not take a written consent from these patients, because implied consent is already over there. So someone was asking me, what is the ideal consent? I have seen a lot of consent forms being, and this is one of the consent forms. Of course, I think it is not very clear that is there, but which I found, and I can share it with you afterwards, that which in the COVID era, whatever I have spoken to you, all those details have been put. At the same time, it does not go overboard in trying to frighten the patient. So this type of a consent, if you start taking, and another thing you have to understand is that get into the habit of taking an Aadhaar card from this patient, because that what happens is, today when the sisters take a consent, if I give my name as Shivkumar Utture, or I give my name as my brother's name Anand Utture, you are not going to know, because we do not take any proof from the patients of who they are exactly. So get into the habit of trying to get an Aadhaar card from that copy from that patient, so that that documentation is already there. What we are finding is just like how we experience in HIV patients. Many of the HIV patients who are positive, they come to us, but they never ever tell us that they are HIV till we get their HIV reports and we find that they are positive. For some reason, the patients are scared to tell us because they feel that they will not get the proper treatment, or they may be shunted out if they say that they are HIV positive. And the same case is happening even in patients who are COVID positive. They don't want to tell that in the society, so they will not tell you that they are positive. But once you ask for the Aadhaar card, I have seen that the patients invariably come out by saying, yes, my test has been done and I have been positive. And if he says that and it's not an emergency surgery, you can always wait for that 15 days or 28 days period for him to become negative before he goes for that surgery. And this is the second part. This is a little big consent form. So this is the second part where all these details are also there, and in which we take the signature of the patient, signature of the witness or the relative also, and of course the signature of the surgeon. And what is the importance of the signature of the surgeon? See, today you can take, as per our laws, we can take the signature, the nurse can take the signature, or the RMO can take the signature, because they are part of your team who treats these patients. But tomorrow in the court of law, if the relatives, if the patient has succumbed, or the patient, if he has undergone some complication, he may tell you that I was not told the details of what I am supposed to undergo, and I was not told even the complications which are going to be more than 10% chances. So because then it is a word of your RMO or your sister, and you may find that these cases come up to you after 3 years, 4 years, and that particular RMO or sister may not be there with you also at that time. So it is going to be the word of your patient against the word of a person who is not going to be there for to give an evidence for on your behalf. So it is better that you sign on that, so that you can always tomorrow say that yes, my signature is there. That means I have explained to the patient whatever the patient complications, routine complications which are expected with this surgery. So this is the last slide. What is the take home message? So you have to understand that consent is a legal requirement and not a formality as we treat it nowadays, or we were treating up till now. Getting a mere signature on a form is not a consent. That consent, all those blanks, as I said, have to be properly filled by the surgeon. Then if a patient is rushed into signing consent without giving sufficient information, it may be invalid in a court of law. This is what I was trying to explain to you. Do not take the consent when you're wheeling the patient into the theater, or after he has been given the pre-medications. Always take a prior consent when the patient is in the proper frame of mind. Often medical professionals either ignore or are ignorant of the requirements of valid consent and its legal implications. So that is why I congratulated you right in the beginning for having this type of a webinar, which is going to be very important, because you may be the best of surgeons. You may have spent years and decades of your life trying to the best of service to the patients, but one case will destroy you. I have seen good surgeons stopping their practice because of one or two cases which are against them, and what hell they have to undergo whenever they have to attend these courts. So I think we should be, even medico legally, we should be well advised of what we are supposed to do and educated of what we are supposed to do. Then attending surgeon obtains surgical consent from patient, plus additional enhanced discussion has to be taken as far as the potential risks are concerned in today's COVID era, and of course the benefits of delaying an operation during this era or trying to do it immediately. So that also has to be discussed in detail with the patient. Then of course all that I have said is there in this discussion, that what are the general risks, what are the risks of undergoing an operation if infected, or he is pre-symptomatic or asymptomatic positive patient, risk of nosocomial contraction of COVID disease, risk of delays in routine and emergency care, risk of healthcare resource rationing. So all this has to be discussed in today's era, especially whenever you are doing, you may not do this in a minor case, but definitely in all the major cases that you are going to tackle in the future, You have to discuss all these cases. And then, of course, attending surgeon has to document either in writing or a video document has to be kept, because he has to save his skin in the future during these difficult times. So thank you very much, and I hope I've answered a lot of questions that may be put up in the future. Thanks.
So thank you very much, Dr. Utture. That was actually fantastic. You summarized it. You've given us all the very salient features of how we should protect ourselves. But despite that, we do have some more questions that we've compiled for you. I obviously, if you answered them, we are not going to compel you to repeat your answers. But just to make sure that we've taken care of these questions. So again, Dr. Shenoy, please unmute your mic, because we need your input as well as Dr. Utture's regarding some of the questions. And I have about 4 or 5 slides, which are basically pre-op, on admission, during surgery, complications. So these are the questions that I need to get from you. So what should be our policy be for testing COVID patients before elective and emergency surgery? This will be like a rapid fire round. So I beg your forgiveness for that. But in the interest of time and in the interest of covering all these questions, please keep your answers to the point if possible.
See, as far as emergency surgery is concerned, you do not have a choice, because your emergency surgery is either a limb saving or a life saving. So you're supposed to do it. But definitely, you must get a PCR test of these patients simultaneously. Don't stop your treatment. You have to go ahead with the treatment, but get a PCR treatment and get an HRCT. See, the biggest advantage of HRCT over the days we are finding, as I already told you, that we can predict up to around to a great extent if this could be a COVID positive or not on HRCT, and you will take adequate precautions as far as that is concerned. And you have to understand, this is not only, this is for both, for the patient's sake and your sake also. Patient's sake, because we have already seen that if he's a positive patient, the chances of morbidity and mortality are very high for these patients. So we have to be ready for the worst situation, and for your sake and your staff's sake, because you are going to take that much extra precaution whenever you are going to treat these patients. As far as elective case is concerned, you must do an HRCT, you must do a PCR, and now the government has also allowed you to get it done as far as your major cases is concerned.
Perfect. Now, how many days? Is there a time that is optimum for this? Because, to get a bed, get the patient in time for an elective surgery, you need to do the test beforehand. So what would be the optimum time?
See, optimum time would be you reserve the bed and 2 days before you do the PCR. PCR now comes within 24 hours. So you give an extra day for that. Whereas HRCT, you can definitely do it 2 days or even 1 day before when he gets admitted, because that takes hardly half an hour.
Right.
So you can get it done that way.
Now, do we limit the number of attendants who should be staying with the patient? And Arvind, please unmute your mic and also chip in with your question, as well as Neeraj, please. So we make sure that all questions are answered on this important topic. So what is your take, Dr. Shenoy, about this? Should we be testing our relatives, the attendant who's coming with the patient, who's going to be staying with the patient as well?
100%, yes. See, I've been telling you, when we were students, we were taught that if at all you get a case of tuberculosis, you have to examine all the other patients at home for tuberculosis, because it is very much possible that you might get others also positive for tuberculosis. In the same way, this is a disease that can be transmitted from person to person. And therefore, I say that if at all there's one positive COVID patient, examining all at home becomes mandatory. It is required.
No, that is if the patient is COVID positive, I understand, but it's a COVID negative patient.
No, when you first examine the patient, first when you get the CT done and you get the PCR done, you come to know whether he's positive or not.
No, so he's negative. So if he's negative, should we still?
No, I don't think so. Okay. I wouldn't say, I would say no, because if at all he's in the window period, it's a different matter. But identifying them in the window period also becomes difficult. And if both these tests are done, you fairly get a picture as to what the condition of the person is.
Dr. Utture, would you agree?
Yeah, no, see, you have to understand, Dr. Mullaji, one thing, that legally you are not allowed to do a PCR test as of today in a asymptomatic patient. I'm not a patient, the relative of the patient. He's not a patient. So you are not even allowed to do it. So what I would say is that try to restrict as much as possible, and that is what I do. I insist that the patient has a single relative who sits with him throughout the period which he is there, you know, in the hospital. Number one. Number two, whenever the relative is there, he sits quietly in a corner. We give him a chair. He does not roam about in the hospital or in the wards. He has a mask put up, and he has to have this hand hygiene which he has to do. And we do not allow them to, like how we were allowing before, they used to have their lunch and their dinners.
Right.
That was absolutely do not allow.
Out there, yeah.
Do not allow them to bring anything else into your hospital beyond themselves, and at the most their purse and their mobiles. So if you do all these things to a great extent, even if they are positive, you will take care. But legally, you are not allowed to test the relatives.
Could we also, there are some countries which are suggesting that if a person is planning to undergo a elective surgery, for 2 weeks, they and the attendant who's going to be coming with them should self-isolate and not be moving around and going out if they can avoid it. Is that a good recommendation?
That is an excellent recommendation, but not in India. You have seen that during the height of the lockdown period, nobody was isolated.
Following,
how do you expect them to do that? It's very, and how will you control it? How will you know that they have?
You can't control it. It's just something that you can put down on as part of your documentation that the patient and the relative will advise. That's it. We cannot enforce that, but it might be something which would work in our favor, Dr. Shenoy. That you thought about it and you've given instructions. Just
can be done. There is no problem, but then the expenses come in, all those other parameters come in.
Okay. Now, what about the doctors and staff testing? For example, the barber, the nurses, everyone who's treating the patient, our surgical team, technicians, various people. Can the patients ask that are they all negative? Should we be tested?
Should I?
Yeah, please. Yeah. Both of you.
See, whatever happens between the doctor and the patient is a pure contract, right?
Yes.
Whenever there's a contract, the rights and liabilities are equal on both the sides. When this HIV problem first came up, hepatitis C problem first came up, both these problems first came up, we doctors always used to get these investigations done essentially to protect ourselves, because if at all we could identify that this particular patient is an HIV positive patient, the precautions that we would be taking the doctors would be taking would be a little more than what you normally take. The question is, if the doctors have a right to understand the COVID status or the HIV status or the hepatitis C status of the patient so as to safeguard him and his team, the same rights are available to the patient as well. I'm saying whenever there's a contract, the rights and liabilities are equal on both the sides. So the question is, does a patient have a right to know the COVID status of the doctor? And I would say 100% yes. On this, there was a very nice incident that took place some 12, 15 years back, and it took place in Tata Memorial. And I'm not going to tell the name of the doctor. He was in a routine testing. He was a surgeon. In routine testing, he was identified to be hepatitis C. And the moment the institution identified him to be hepatitis C, they grounded him. They said, you only attend to the OPD work. You do not operate, because when you operate, suppose you have a needle prick on your hand and your body fluid enters into the peritoneum of the patient or anywhere into the patient, there's a high possibility that the hepatitis C will go to the patient. And therefore, they said, you only look after the OPDs. The moment this kind of an order was given by the central government, because Tata Memorial belongs to the central government, he filed a writ petition in the Bombay High Court saying that, well, it comes against my livelihood and I cannot be prevented from operating. Now, this particular case did not reach its logical conclusion because I'm given to understand that this particular doctor expired during the pendency of the case. So this case was not decided. But if at all this case was to be decided by me, suppose I were to decide this case, I would say one thing very clearly. See, here there are two rights involved. One is the right of the doctor, the surgeon, to operate. And second is the right of the community at large from preventing from getting infected. So whenever there's a clash between the right of an individual and the right of the society, the community right will always override that of an individual. That is why, if at all the patient insists, this incident must not have come so far, this issue must not have come so far, but if at all the patient insists that I want to know the HIV, the COVID status of the doctor concerned, I think we doctors are justified in giving it to them. And if at all the doctor is identified to be COVID positive, he should not associate with any of the treatment that he gives to the patients, either COVID positive patients or maybe COVID non-COVID patients as well. No. Now, there is only one decided case on this, whether the patients have a right to know the status of the doctor, and this is with respect to HIV. And there's an American case where a dentist was identified to be HIV positive. The matter went to the court whether he should be grounded or not, whether he should be prevented or not. And the American courts have ruled saying that if at all the doctor takes universal, because the dentist adopts all the universal precautions, and if at all he is properly counseled from time to time, there is absolutely no problem for him to look after his patients. That is the law that is settled on this. But the Bombay High Court couldn't decide on this. Maybe it would have said the community right will always override the individual right. That is
So
the right
currently there is no guidance from the Indian courts.
No, but when there are no decided cases by the Indian courts,
right,
and if at all a foreign judgment is kept before the judges, the
then
foreign judgments have got a persuasive value.
Okay.
They definitely can be relied upon.
Dr. Utture, do you agree?
In this one aspect, I would like to tell.
Yes, please.
Even if the patients ask for the status
Good
of the
status,
doctor, are you allowed legally to get your PCR done when you're symptomatic? No.
Exactly.
So if you're not allowed by the law to get yourself, instead, if you go to get yourself tested, you may be hauled up by the government, and they may again put it that your registration will be cancelled, this will be done. So
don't the doctors fall into the high risk category by which they can get it done?
No. They fall, not because they are treating. If they are taking adequate precautions, definitely they will not fall into the high risk, because even high risk, if you see how it is defined, even when the patient is admitted in a hospital and turns out to be positive, those high risk staff or members are those who do not have proper PPEs when they have examined the patient or treated the patient. So if the doctor is going to take proper care of being himself protected, he does not come under the high risk category at all. Now, if you ask me, there are two aspects. One is the legal aspect, which I just now told you that legally we are not allowed to get ourselves tested. The other is the practical aspect, which we are also now fighting with the government, that minimum once in 15 days, the staff, the health workers must be allowed to get themselves tested for PCR, because we are finding almost around 65 to 70% who are asymptomatic, who themselves do not know that they are infected. And the hospital can be a hotspot as far as spreading this disease is concerned. But unfortunately, the practical aspect you have to take into consideration as far as the government is also concerned, that we do not have that many PCR test kits available. So it is not possible. Yes, down the line, if they can, millions of test kits will be available very easily or something like that, then of course we can go ahead and insist that every 15 days, all the healthcare workers must be tested for that. But that day is not today.
Okay. Arvind, anything additional that you wanted in these pre-op testing?
That particular statement by Dr. Utture, I think answered most of the questions. So if the onus lies on the patient or any healthcare worker who points a finger at you, that you have caused the infection, the onus lies on him to prove it. That is quite far-reaching statement, which cuts across all interfaces at where we work. So that answers most of the questions. Having said that,
Dr. Kulkarni, can I add something over here?
Yeah,
please.
One thing is that the onus is always on the person who makes the allegation. If the patient makes the allegation that I picked the infection from the doctor or the hospital, the onus is on him. That is one. There's another very important point which I feel I must tell you, and that is there is an inbuilt protection in the Epidemic Act. Do you know this? Epidemic Diseases Act is just a two-page document, containing only 4 sections. And Section 4 of that particular act gives a protection to all those people who are working at the time of the epidemic, under the auspices of the Epidemic Act. So you have an inbuilt protection. Even if you are taken to the court, you can quote this particular provision, section 4 of the Epidemic Diseases Act 1897, which gives you a protection. You cannot be sued. And even if you are sued, 100% you will be exonerated.
Arvind, I have sent you some questions from OrthoTV. Can you check that? It's on the Zoom chat.
Dr. Mullaji.
Yes.
I would like to a little bit interfere in whatever this reading of this act is concerned as far as good faith is concerned, because this is also what we have been asking, and Maharashtra Medical Council has also passed in the council that the doctor should be protected under because the treatment protocols are changing day by day. So today, if we have treated a patient in a particular way and he succumbs after say 8 days, 10 days, when the protocol changes, he may sue the doctor. Now, this discussion again I have had with even Supreme Court lawyers and judges. As far as that act is concerned, that act, the protection in good faith, which is written over there, this sentence is there in every act of the government. And what this protects is these administrators from taking any decisions under this act. This protection, unfortunately, the legal opinion is that it does not protect us while we are treating these patients. We are trying our best. We have written to the MCI also, and we have written to the government that the doctors should be protected because this is a new disease. We ourselves do not know. ICMR doesn't know. WHO doesn't know how to treat this disease. They are also learning, and hence the way that we treat this disease, we should be protected under this act. But unfortunately, it has not yet gone through with the government. We are still pursuing that. So I think we should a little bit be careful, because what is written in that act is for the administrators under that act too. And if you see in that disaster, what it is said that they can stop the train lines, they can stop whoever is moving out and all that.
Right.
When they do that, nobody can sue them for doing that. That is what the interpretation I got from the Supreme Court lawyers.
So that is not like blanket coverage for us. So we've got to take our precautions. We've got to be very careful. Okay. So
Dr. Mullaji, there are some questions from OrthoTV.
Yeah, go ahead, please.
Yeah. So these are some basic questions. Do we need to take consent for OPD diabetic wound debridement dressing? Or it is implied?
If you are doing debridement, if you are doing a dressing, you do not require. But if you are, as I said, if you are doing any procedure, you should take a consent.
Okay. What about the complication rate from 2 to 10%, to tell or not to tell? So you said that about 10% you should tell all the complications.
Yes. See, the answer to this question is, if you go purely by the act and view the judgment, and that is the law today, you need not. But if the patient asks a pointed question, you must confirm.
Okay.
Like the patient can say, what are the possibilities of me dying during the course of surgery? Well, you must tell. As long as the patient does not say anything about it, you may keep quiet.
To do CT scan, does the diagnostic center wants COVID PCT test result? Now they are doing chest X-ray also. Now they are not doing chest X-ray also. So it's not compulsory?
No, I don't think, because I have been sending my patients regularly for HRCT. Because I work in 2 of the corporate hospitals also. So and I'm on one of the boards also. So what we have done over there is that the patient is taken in a particular, we have put on a protocol of and SOPs of how a patient should be taken for that HRCT, and what are the precautions to be taken by the staff, not only by the staff, even before taking the patients and after taking the patients, how you sterilize or sanitize that whole CT center. And that has been done. I don't think anywhere they are asking for any report of PCR positivity or negativity before doing HRCT.
So one Dr. Jawahar Jetwa from Gujarat, he has asked a question. So he's an orthopedic surgeon. He is whether the consent which we need to take, has the judiciary or association of judges or any panel, have they drafted such a consent? The one which you showed, the consent which you showed, has it been, is there any specific format or which can be made available to everyone, so it becomes a little easy for the doctors to do the consent taking?
Consent is basically a contract between 2 parties, and the contract is always tailor-made to suit both the parties, remember, and that is why there can never be a fixed format. It depends upon what you are consenting for, and the drafting of the consent accordingly changes.
Yeah, but a lot of points that Dr. Utture mentioned are common to these patients, right? These COVID patients, that this may be the case, this may be the case. So that can all be incorporated in whatever is the routine consent form that we may be taking for a given procedure. That one bit can be just added on to each of these. And is there that one bit which Dr. Utture can perhaps share with us so that all of us use the same terminology in this state, for example?
That is what I've been advising all the organizations also, because consent, as Dr. Shenoy rightly put it, that it differs from patient to patient and from faculty to faculty. So I've been talking to a lot of heads of organizations, like the gynec, they have come out with consent, the ophthalmic have come out with consent. I think all organizations should, as you said, the organization should come out with a standard consent form. We have written from MMC point of view, because we also want to try to put up something to help our doctors on the MMC website and our advisory, that this should be the format of the consent forms. We are working on that also. So if every organization can come out with that, and as you said, some of the points as far as COVID problem is concerned can be common, but the rest of the, because consent cannot be different for COVID and different, you cannot take 2-3 consents like that. You have to take one consent in one form, so the rest of the things can be specific for that particular faculty, and you can have below that a commonality as far as the COVID problem is concerned. You're right.
Correct. So that little sort of additional bit, if we can all get together, or maybe if MMC does it, that'll be great. And we can all incorporate it in whatever procedure that we are doing. So that would make it uniform across the board then. That'd be great.
Sure.
Now, what about this question I think you raised, that a lot of our team members and people working with us, if they get COVID, what about them? Our assistants, nurses, are we liable, or the hospital liable for this?
Well, the liability can come if they can prove that they have been not given proper. Pardon?
Yeah, so it's basically proving it. That's what Dr. Shenoy mentioned.
No. If they can prove that they have not been given proper protection,
right,
then we are liable for it definitely. Because today you tell me, in any hospital, and we have seen a lot of residents and a lot of nursing staff and all getting tuberculosis after working in hospitals. Do they sue you? They don't sue you. Okay. So, but in this problem, if they can prove that you have not given them proper protection and they have asked for it, then definitely you are liable. That is a legal aspect. But then I feel, as far as the moral aspect is concerned, because whenever we do medical practice, you have a legal aspect and you have a moral responsibility. I think they are working for you. They are not used to, or they do not have that much knowledge as you have of this subject. So your first moral responsibility is to teach them what to do and what not to do. The second because even they cannot, again, this staff, especially who are going home after an 8 hours duty, they cannot prove that they have got it in the hospital. They can get it, see, almost like a community spread, let us be very frank, especially in Mumbai. So they can get it while traveling, we can get it when they go to their house, into their society or anything. So it is your moral duty to teach them what they should do even when they go out of the hospital. And when they are in the hospital, the maximum protection that you can give as per protocol, you should give to them. That is your duty.
Okay, great. Then certain issues come up because a lot of us are surgeons. So in the admission process and the operation theater, should we be only admitting patients to single rooms? What about the status in twin, triple, general ward? Are there some specific requirements? Should we follow that 2-meter rule when they get admitted?
COVID or the non-COVID group you are referring to?
No, these are elective patients who are non-COVID on admission.
What I advise everybody when they ask me, these hospitals ask me, is that if you have obviously elective patients, you have done the PCR test and the HRCT, which both are negative. Having said that, I think they can be admitted in the general wards also. But it is high time we start keeping the space requirement between the two beds. We have to follow that. We have to follow where we have to strictly tell the patients and the relatives that they are not supposed to be roaming about in the ward unless they're doing it alone, and you ask them to get it done post operatively, that they should be mobile or something like that. And plus, if possible, they should be having, all of them should be wearing a mask, a cloth mask. You do not require anything beyond that. They should be, if they are not uncomfortable, I'm not talking about the immediate post-operative period, but after that, they should be having a cloth mask there. And you can take these patients in the general ward if the distancing and the hand sanitization and cloth mask are put in place.
Because of the scarcity of the beds, I've always been saying, in one room, if at all there are 2 COVID patients, they can be accommodated. Diagnosed COVID patients in one room, 2 diagnosed COVID patients can be accommodated. In one room, 2 suspected COVID patients can be accommodated. But a proved patient with a suspected patient should never be kept. That is what I've been always saying. And if at all the person is absolutely clean, well, 20% of the beds are given to clean patients today. 80% are booked as COVID patients, COVID beds. So if at all the patient is absolutely clean, he can be kept in the 20% beds.
In the 20%, but in a single or a twin room, that you're not worried about.
Yeah, if it is a both patients are non-COVID,
right,
room can be shared by them, but both of them have got to be non-COVID. If at all they are suspected, both of them have got to be suspected. Only then they can share a room. Proved COVID, 2 patients can definitely share a room, provided both of them are proved COVID.
Correct.
This is done essentially because there is scarcity of beds too.
Yes.
Dr. Mulaji,
yes.
This problem more than elective surgery comes when you're doing an emergency surgery.
Emergency surgery, that's the problem.
Now, when you're doing an emergency surgery, unless proved otherwise, you have to treat every patient that he is going to be potentially positive. So there you require a proper triaging when he comes to the hospital, and there you require to place him in a single room for 24 hours, for the first 24 hours till his reports come in. Once his reports come in that they are negative, his HRCT shows that they are negative, you can shift him to whichever ward you want. But this problem is especially we experience it when there is an emergency case.
Right. Now, in the operating theater, should all the personnel be wearing PPE? This is the question that has come up.
No. The operating person and the assistants, and if it is you are giving a general anesthesia, then the anesthetist, they have to be in a full PPE. See, PPE can be a simple mask, it is a protective equipment.
Right.
So I take it that when you are saying PPE, it is a full PPE where you have to be in the full gown with the mask and the gloves and the goggles and everything. See, I don't know. You have to wear a PPE to know how difficult it is to work in a PPE. So you cannot expect everybody to be there. Plus, if your ancillary staff is not coming in direct contact with the fluids of the patient, they do not require to be in a full PPE. They can be in the surgical, what normally we wear as an HIV gown we used to wear normally, so that it is impervious, that the fluids do not touch their body. So that is more than enough for them with a mask and gloves. But those are the minimum things that they require.
The bigger problem in orthopedics is drilling, sawing, use of machinery and equipment whereby this aerosolization is occurring. And that can go in other parts of the room. So it's not just the body fluids in the immediate vicinity of the patient, but at a little distance away as well. So that's the reason why this
orthopedics is a completely different ball game. And if you see, even the world statistics are showing that the general practitioners or family physicians are number 1 as far as being infected. After that is the ICU and physicians who are working in COVID ward. And the third is orthopedic surgeons who are getting infected, and not only infected because they are exposed to this aerosol. The viral load also is very high. So there are even a lot of orthopedic surgeons have succumbed to this disease. So you have to take extra care And that is the reason why I mentioned in one of my slides that if you can postpone any case safely without causing much harm to the patient, please, especially orthopedic cases, ENT cases, that is another thing that you must postpone. Try to postpone these cases. And what you can do is you can restrict the number of personnel entering your theater.
Yeah.
And as far as possible, whenever you're doing such major surgeries where you require a lot of sawing done or anything where the aerosols is high, try to do it in a theater which has got a negative pressure mechanism, which is there, which sucks in all, just like how it is in the aeroplanes. It sucks in all the aerosols. So these are the
It's the reverse. Most of us have these laminar flow theaters which are positive and not negative, and they say that it requires major engineering to change it to negative pressure. So they're saying, because a lot of us use these helmets in any case for our routine surgery, and they're saying don't even use the helmets because you can't sterilize them, you can't clean the filters and so on. So this is a bit of an issue for elective surgery in orthopedics because of the aerosol.
Okay, Arvind wanted to ask
Arvind,
something.
you have some point about this?
Arvind, Arvind, can you hear? Yeah, go ahead.
Yeah, so wearing the full PPE, I don't think you can work for more than half an hour, 45 minutes, operating on this patient. I've been to the ICU with the full PPE. You drench like crazy within the gown. So forget operating with the level 2 PPE. But for the regular ones, I don't have any experience with the COVID positive patient. For a non-COVID patient, we are using level 1 PP, that is with N95 mask and this one visors and protection for your feet. Nothing more than this.
Okay.
We have a laminar flow theater, but so most of our patients, we are doing surgeries in prone position. And so when the anesthetist is inducing the patient, we go out. So only when the patient is to be positioned, that is where we enter in. So we're not given much heat to this negative pressure.
Okay.
But I would just request you one thing, Dr. Kulkarni, that please wear an impervious apron minimum.
So that is what we are working. That is something which you're wearing.
Not just the OT gown.
But the level 2 PP which we wear in the ICU, it is impossible to operate with that.
Dr. Right. Mundaji, the last point in the previous slide, can you just show the previous slide?
Certainly.
Does surgery need to be performed in the operation theater reserved for non-COVID patients? See, the question is, a COVID positive patient to be operated in a non-COVID OT? Does it mean that?
No. So there are some hospitals where they have more than one operation theater.
Yeah. I'll tell you this. I'll answer this. See, there is a concept known as the dedicated theater, and this concept is very much there in ophthalmic cases. There are theaters that are used for ophthalmic surgeries, are only meant for ophthalmic surgeries, and nobody else operates any other, takes up any other surgery there. There is another concept known as septic theaters. In septic theaters, a clean case is never taken. Applying those concepts, I would say that if at all a person is COVID positive, he must be operated only in a COVID positive operation theater. A non-COVID patients should be operated in non-COVID operation theaters. In short, what I mean to say is you must have dedicated COVID operation theater. That is what my take on this.
And the non-COVID patient should be therefore done in non-COVID.
Only non-COVID, yes.
Correct.
So COVID operation theaters are dedicated operation theaters only meant for COVID patients.
Perfect. Okay. And this, I think, is probably the last slide where we are talking about complications now. One is in anticipation that there may be a small chance of the patient developing a complication. We may not have support systems, like a vascular surgeon may not be present or so on in that setting. Because of this COVID situation, they may not be operating on, may not be available. So should these rare complications be kept in mind? They may require a ventilator, for example. Again, a rare possibility where the hospital either doesn't have a ventilator available or does not have an ICU bed available. Should you just postpone that surgery on the remote chance of a small complication occurring?
if at all the facilities are not available, it is best not to operate. And here there's a very nice case on this. I will tell you. There was a patient who had a fracture of the forearm, radius ulna, and he was taken up for close reduction. And I think the amount of anesthesia, he must have been a little light. So when it was reduced, the patient had a cardiac arrest.
Oh.
Subsequently, the patient could not be revived. The stand taken by the anesthetist was defibrillator was not provided by the hospital owner, and that is why I could not revive the patient. This was the case. You know, the ruling given was very clear. The court said that if at all you were aware that the defibrillator was not available, and if at all you were aware that the defibrillator would be required, why did you operate? You should not have operated, because there is a very nice doctrine in law which is known as doctrine of estoppel. The doctrine of estoppel says that you are stopped from contending something which you have already accepted. If the anesthetist accepted to go ahead with the case without the defibrillator, the anesthetist later on cannot say that the defibrillator, had it been there, I could have saved the patient.
Okay.
In the same way, if at all you are sure that there is a possibility that the vascular surgeon might be required, there is a possibility that a ventilator may be required.
The possibility is very rare.
And the same is not there. If that is the case, then it's best not to operate upon the patient.
No,
it is a very, very rare complication.
Being it's an extremely low chance, it may not have.
I agree it might be rare, but if at all it does happen, then you are
like to stand down.
Yeah, you are in trouble.
Okay. Arvind, does that answer your query?
No, but it is so rare. So, for example, patient develops a complication, you need to rush and do a CT or a MR, and there's collapse of the hospital and the healthcare, and there's no radiologist who's coming on that day, things like that. So, which are not under our control.
The law is very clear. The law says a complication, the manifestation of a complication or manifestation of an inherent risk is not negligence. It is very clear. But what is negligence is not identifying it in time and not treating it. So if at all you do not have the wherewithal to treat the patient, identify, you may be able to. If at all you don't have the infrastructure to treat the patient, that in the eyes of law will be negligence.
And how much is the hospital responsible? Vicariously responsible?
Vicariously, the hospital is accountable. It is known as vicarious liability.
Yeah, but the hospital pass the buck back on to you and say that we did not know that you're admitting a patient who's likely to have this particular complication. Otherwise, we would have not let you do it. They cannot.
So that depends. I think all these things which are very rare will go on to the who has a better lawyer and who is your judge.
Liar or lawyer?
Liar.
So Dr. Utture, in this situation, I would like to ask something totally up and beyond. I practice in a nursing home. Okay, my nursing home does not have ICU, but we have a ventilatory support in the anesthesia machine, and it has happened to me in the past. So patient has not died on table, touch wood, but patient has to be shifted to a higher center. In such a situation, I am always in the same situation, Dr. Mullaji. If you are going to face that situation for the first time, I have always been in that situation for the last 15 years of my life. So these rare complications, I just see that if there is some calcification of the artery, I would not do it in a nursing home, then I would do it in a bigger setup. But if they are routine patients, like younger patients, or maybe a TKR or a spine surgery, which are younger patients comparatively and medically fit otherwise, those patients will having a chance of such a complication where another super specialist required is very rare. So if it is like that, then all nursing homes have to go shut. We don't have anything, any backup in that matter. We don't have a vascular surgeon anytime.
Absolutely.
See, in this, there are two aspects. The first aspect is, have you taken up a patient in that nursing home where you anticipate that there would be a problem, but you don't have the facility? That is number one. So that means that you have taken up a very major case in a place which does not have that facility. Number two, if you have taken up a case where you are anticipating there's going to be a lot of bleeding, but there is no blood bank available, so you could not give blood, and then the patient has succumbed. So that is number one. And number two, as Dr. Shenoy has already told you, that complication does not mean negligence. How you take care once that complication has taken place, that is negligence. If you have not taken proper care of that patient post-operative. It is your duty that once there is a complication to see that the patient gets the proper treatment as far as that complication. Just to give you a simple example, there has been a case where there has been a mishap, anesthesia mishap in a patient, and the patient has sued that doctor, but then that anesthesia mishap is one of the rare mishaps which have been mentioned in the books, but it is extremely rare. And after that mishap, the patient has been taken to a tertiary center and given proper treatment, etc., etc. But of course, the patient had some complication which was permanent. But that person that or that anesthetist was never held liable for that. So, not diagnosing a complication post-operatively and not treating it in the standard ways as is given in the books, that is going to be your negligence and not that the complication has happened.
Okay,
Okay,
that's
thank you.
excellent. I think that puts to rest a lot of concerns that people had in this situation. So that's wonderful. And the last bit is now at the time of discharge and insurance. Now, for example, do we need to test these patients prior to discharge?
No, legally you are not allowed if he is asymptomatic.
Right. HCQ, should we safeguard ourselves by prescribing any of these drugs, or I mean, nobody really knows what works, so you don't really need to give anything additional, is it?
For whom? For whom? The patient?
For the patients. I mean, not as adjunct treatment, basically, not as part of whatever you're doing. You may be doing, let's say, a spine surgery, but should you also then advise them to take some anti-COVID treatment such as HCQ?
No, as far as ICMR is concerned, the directive is that HCQ as a prophylaxis is restricted only to the healthcare workers. That also, if they don't have any medical problems like heart problems or whatever it is, that is number one. And as a treatment for COVID positive patients. So even in between, they were thinking of, especially in the red hotspot areas, that they should use it as a prophylaxis by giving it to everybody in that area. But that has been shot down by both ICMR and WHO also. And I don't think you are justified, because if you give HCQ and God forbid some complication happens, you will be held responsible.
Should, by the same token, people who own nursing homes, small nursing homes, or even in hospitals, should all the staff be given HCQ? I mean, as they qualify as healthcare workers, so should Neeraj, for example, be giving everyone in his hospital HCQ? The X-ray technician, the ward boys, etc.
If your staff you feel are going to be exposed, I think it is your moral duty to give them HCQ to whatever. See, it has not been proved that it definitely helps, but that is the only weapon that is left for us as a prophylaxis. And if they don't have any complications, or you get the ECG done, which is normal, I have given it to my staff. I have myself taken HCQ, and I'm still taking it, because as I told you that this is a new disease. We don't know what we are handling. So, we are clutching at straws. So one of that straw is an HCQ, which to some extent ICMR also says does protect you if you get positive. So you can, and it's a cheap drug, not much of complications, being used quite very extensively in India. So it does not have much complications. So there's nothing wrong in you giving it to your health workers also.
I am also taking.
I would like to add a point here, sir. I am, as you said, I am also giving and I am also taking myself. But I see to it that I have done everybody who's above 50 years, I have done their ECG, whether they are having a heart problem or not. And if any problem in the ECG, one of the physiotherapists had a problem, so I stopped. She has herself said, I have a heart issue, I'm not going to take it. And there was this ward boy who basically is taking some medicines for his heart. I said, you cannot take, I will not do your ECG also. If you want to take, you do your ECG. He refused for the ECG, I refused him medicine. The only thing which I am doing, because I have only staff of say 15 people, I take about 30 tablets a bottle and distribute every week myself. The same day when I am taking it, they are also getting it from my hand only. So they are not allowed to take it on their own. They are not given a stock of 1 week, so that they cannot give it to anyone. Only 2 tablets are given every day, every week. And that is what I do for my staff and myself.
Only thing is, I would request you that after the 4th dose, just repeat an ECG.
Yeah, I will do that, because 4th dose is yet to come. So next week, I'm going to do the 4th dose and repeat the ECG. That's a very good tip. Thank you very much, sir. So Dr. Gopinath, you wanted to say something?
No, it's perfect. I think
Yeah, okay.
I'm also taking.
Dr. Shenoy is saying that he himself is taking the drug even when he is not seeing patients. I like that.
No, but my wife is very much with me, na. My
Okay.
wife is still with me, na.
So I think we had a very good session.
Just last point, Neeraj, I wanted Dr. Shenoy's take on it. The insurance companies often don't pay for various things, in the patient's bill. Now, there's a lot of this equipment, PPE, etc., testing materials, which will be added to the patient's bill. And if the insurance company, are they, can they not pay for all this?
According to me, the PPE kits, if at all, they are billed in a reasonable amount, not like what happened in Fortis some time back. The insurance company should pay because that is a requirement today. It is not luxury. Remember, it is not luxury, but it's a basic requirement. So all PPE kits, if at all they are billed in reasonable quantity, I think the insurance company should pay it.
I'll just, if I can just share a screen. Just
Yes, sir, sure.
I have got, because this is a new thing that has come up as far as the recommendations of the this is concerned.
So they had given some fixed charges that you cannot charge beyond this, something like that.
Yes.
Luckily, I have got that screen also because someone yesterday had asked me about this. So let me just share it. Yeah, these are the guidelines which have just come in by the yeah. So here it says very in categorically that whatever you use for the COVID has to be given by the insurance company. So that has been, we have been fighting for this. This has just come on the 11th of this month that they have given that they, the insurance company should, under the COVID, this problems, they should allow all these things to be done. But of course, as Dr. Shenoy said, like some hospitals who are charging, per patient for all the PPEs of that day, that should not be allowed.
Yeah, that should never happen.
That should not, because it should be reasonable. They have said over there that whatever is allowed should be under the reasonable settlement, and it should be settled. So this is the document that has been given. As far, oh, sorry. This is telemedicine.
This is telemedicine, sir. That is what we are confused.
No, sorry. Just 1 minute. I have got take home legal protection. Oh, sorry. I don't think I have kept it.
So
but
you
there
can
is a
just share
document.
it.
I will share it afterwards with you, which has just come out just these 3-4 days back, which has come out, which says that the IRDA has said that they are supposed to pay for all the insurance of COVID also.
Okay, thank you very much, sir. Thank you, Dr. Gopinath Shenoy, and thank you, Dr. Shivkumar Utture, for sparing their precious time on Sunday morning, which extended to our lunchtime. I am hoping that everybody has a good Sunday and we go back to work very soon. I hope, and this is going, everybody should know that this is going to be a new normal. Living with COVID is what we should learn. That is the most important thing. And the main take-home messages have already been driven very well. And we thank our moderator, Dr. Arun Mullaji and Dr. Arvind Kulkarni for sparing their time. Thank you very much and bye-bye.
Thank you very much. Thank you all.